Okay. Thanks everybody for joining us today or from the webinar, whenever you're watching this. My name is Merceydes Morassi, and as you can see, what these letters next to my name mean, I am a board certified behavior analyst, a licensed mental health counselor. The LPC just means licensed in California as well, and a certified integrative mental health professional, which just means that I kind of have a more holistic, natural view and approach when doing mental health counseling. So that's the little bit about me, and we're going to talk about mental health issues that are common in children and adolescents. It's a three-part webinar, and so I don't think today is going to be super useful to you unless you do the other two parts of the webinar, because the other two parts we're really going to dig into some of the diagnoses that you're going to see in these kids, talk about like the symptoms and all sorts of things. But today is more like a brief overview, just kind of like opening the book and getting a little, I guess what we could call this the abstract. So I definitely think the other two webinars will be beneficial. So hopefully see you there. Okay, so the diagnoses that we're going to discuss over the next three, well, this one included, over the next three webinars would include major depressive disorder. And so there's all sorts of different kind of categories or specifiers for major depressive disorder. And the two that are most applicable would be when we're looking at the way it presents in children, and also what we call the atypical presentation, because the atypical presentation is very common in women, especially young women. So a lot of times when I see an adolescent girl presenting with depression, it presents atypically. I believe we do all the depression discussion in the third webinar. We're also going to talk about autism spectrum disorder. That's obviously a very common diagnosis, growing in, it's increasingly more prevalent in the population, and also diagnosed pretty young. So a lot of the kiddos that are in our elementary schools, middle schools, high schools, by the time they're in middle and high, they've probably already been diagnosed. But early diagnosis is usually around like 3, 4, 5 when we first catch these kids and see the symptoms of autism spectrum. So likely you will have kids in your classes that have this diagnosis. Oppositional defiant, we often call that ODD. We're not going to talk too much about that in this PowerPoint, but most of you are somewhat familiar at least with that term. And then conduct disorder is a relative to ODD, but kind of more intense and severe. Attention deficit hyperactivity disorder, ADHD. That's what it's called. There is no more ADD. When the DSM was rewritten, we got rid of ADD. So everything falls under the ADHD umbrella. We just specify which type of ADHD. That's a very, very common diagnosis. And that's one I think I'm going to talk a lot about, a little bit even today, but definitely webinar 2, we really get into ADHD because a lot of you will see kids with ADHD. Some of you might have ADHD yourself. And so, as I said, it's really common. Then obviously social anxiety disorder, that tends to be like very prevalent around puberty, really. So a lot of times by mid-20s, people have grown out of this, or it's at least lessened in intensity. But in the, adolescent years, social anxiety is pretty high. And then we have eating disorders, which also tend to have an onset around adolescence, particularly for adolescent girls who are going through puberty. So we'll cover those a little bit. And then we will definitely talk about suicide because unfortunately, as the statistics indicate, which we will talk about in a minute here, that is on the rise. It's on the rise for adults, it's on the rise for adolescents, and unfortunately, it's even on the rise for children. So the little last bullet here says there must be an impairment in functioning in order to meet criteria for a diagnosis, and that the problem should be observable across multiple contexts. And what that means, I just kind of put that in there so that I could explain to you guys. As clinicians, when we diagnose somebody, we can't just say, oh, this kid's got an issue, therefore we're going to slap a label on them. We can't do that. What we have to look at is we say, okay, there's obviously symptoms, there's obviously things happening, but is there an impairment in functioning? And so what that means is if this kid is, I don't know, rambunctious or inattentive, but they're able to turn in their assignments on time. They have relationship with their peers. They aren't having issues at home, excuse me, with the family. There's no impairment in functioning. For adults, it's a little bit easier to kind of figure out where there's impairment in functioning because we have occupational tasks, we have, romantic and familial relationships, we have more responsibilities. So with adults, we can say, oh, they're neglecting in their responsibilities, therefore there's an impairment in functioning. With kids, we still have to figure that out. We still have to say, are these symptoms in some way negatively affecting them? Also, we look at multiple contexts. This is very, very important, and something that those of us who are behavior analysts are really good at is we learn to very much analyze the environment that the child is in, because if problems only arise in one environment, that's indicative of a problem of the environment, not a problem of the child. And so hopefully, the clinicians that are assessing these kids are very careful to make sure that if we have, for example, a teacher saying, oh, little Johnny's a menace, but mom is saying he's a saint, we go, all right, wait a minute, maybe the problem isn't little Johnny. In addition, as clinicians, we're also trained to assess for cultural validity. So what that also means is that sometimes when kids or people, whoever, but I'm going to keep referring to kids because that's what we're talking about, right? When kids are presenting with issues, we have to also understand the cultural context in which they were raised. What are the norms for their culture? So we wouldn't want to pathologize something that is normal based on their cultural or ethnic background. So that's the little snippet of what we're going to diagnose and just something to consider. We're going to talk about some stats. Okay, so I have a bunch of stats quoted here. The prevalence, globally, nearly 15% of young people ages 10 to 19 experience a mental health disorder. I think I want to just stop right there for 1 second and specify. This is a mental health disorder. And when we're diagnosing kids with disorders, okay, we as clinicians have a certain number of criteria we have to meet according to the DSM. So for example, any diagnosis, let's just say, let's say they list 10 different symptoms and they say, client must meet 5 out of 10 symptoms and symptoms must be present for blank specified amount of time. So if you have someone presenting for therapy and they only meet 4 out of the 10 symptoms instead of 5 out of 10, or they've only been presenting, like, let me give you a more specific example. So for major depressive disorder, you have to have the symptoms for 2 weeks. Let's say you have a kid presenting, but they've only had the symptoms for a week and a half. They would not meet criteria for the disorder. And so the reason why I bring that up is because it's this stat. Globally, nearly 15% of young people ages 10 to 19 experience a mental health disorder, meaning they have full criteria, all the symptoms to meet criteria for the disorder. But there are probably countless others that don't meet criteria, that haven't been diagnosed with a disorder, but are still in some way suffering. So I just kind of wanted to point that out. This accounts for 13% of the global burden of disease in this age group. In 2016, almost 20% of children in the United States ages 2 to 8, that's a very young population. What is that, 3rd grade and under, had a diagnosed mental, behavioral, or developmental disorder. In 2018 through 2019, about 15% of adolescents ages 12 to 17 had a major depressive episode. 37% had persistent feelings of sadness or hopelessness, and nearly 20% reported that they had considered suicide. That hopefully is as alarming to you as it is to me, the idea that 20% of adolescents aged 12 to 17 have seriously considered suicide. And I'm guessing, I didn't do that study, so I don't know their exact criterion, but usually as clinicians, if we say seriously considering suicide, that means that there's some degree of planning or contemplation how it would be carried out. Whereas passive ideas of death, like, what if I didn't wake up or whatever, that's a lot more common. So 20% are actually getting to a place where they're really thinking about how they would do this. And that's terrifying. A study conducted by the Health Resources and Services Administration showed that between 2016 and 2020, the number of children ages 3 to 17 diagnosed with depression grew by 27%. Another very alarming statistic. The idea that a 3-year-old could be depressed seems like it seems like outlandish to a lot of us. Like, what? You're 3. What could you possibly be depressed about? But some more alarming stats on that are we actually, when it comes to suicide attempts, there have been suicide attempts in children as young as 3 and 5 years old. And so, yes, depression can happen very, very young. It's less common when they're that young. Depression, really, the rates start to spike around adolescence. But yeah, it can happen. And so another very sobering, scary statistic. Okay. Among adolescents aged 12 to 17, the percentage who received mental health services in a specialty mental health setting. So what that would look like is, so maybe you would, like, for example, in South Florida, we have eating disorder clinics and we have substance abuse clinics that specialize in both inpatient or outpatient. Then, of course, there's inpatient hospital settings. So it might be something like that. But among adolescents 12 to 17, those that received the mental health services in a special mental health setting increased from 11.8% to 16.7%. And over that same period, the percentage who received mental health services in a general medical setting in the past year increased from 2.7 to 3.7. So that might be the pediatrician or general doctor, something like that. The percentage who received mental health services in an education setting in the past year increased from 12%, well, 12.1, to about 15.4% in 2019. So that shows that kids are receiving more services, mental health related services in school settings. This is why trainings like this are particularly important for teachers and other school staff. Boys ages 2 to 8 years old were more likely than girls to have a mental, behavioral, or developmental disorder. I will say this, learning disabilities and autism spectrum disorder are much more common, much more prevalent in boys than girls. For adolescent girls ages 12 to 17, there has been a sharp and sustained increase in depression cases since 2009. In addition, more than 1/5 of children living below the 100% of the poverty threshold had a mental, behavioral, or developmental disorder. And age and poverty level affected the likelihood of children receiving treatment for anxiety, depression, or behavioral problems. Poverty has long been identified as a huge risk factor for a variety of issues, and one of them being mental health issues. So maybe that indicates that we have to pay particular attention to our kids who do come from the lower socioeconomic realms and make sure that they are thriving. I should probably quickly touch on the stat about adolescent girls. Adolescent girls, so even though boys have a tendency more towards the learning disabilities, autism spectrum, those are usually identified pretty young, around, a lot of times elementary school. However, for adolescents, when we start getting into middle school and high school, things shift a bit where we start seeing more girls needing mental health help, because right around those, puberty years, rates of eating disorders start to rise for girls, rates of depression start to rise for girls. So girls are at real high risk right around puberty. Okay. Mental health challenges were the leading cause of disability and poor life outcomes in young people, even before the COVID-19 public health emergency, with up to 20% of children ages 3 to 17 in the United States having a mental, emotional, developmental, or behavioral disorder. I thought that statistic was particularly interesting because a lot of us have paid attention to the effects of COVID, the lockdowns, the mandates, but also the disease itself. And we've all kind of looked at that and said, wow, this has definitely impacted the kids. But this stat is saying, look, like even before that happened, we had mental health crises kind of looming in the background when it comes to these kids. Sorry. The 2013 to 2019 data showed that nearly 10% of children ages 3 to 17 were diagnosed with attention deficit disorder or anxiety. That's kind of a lot. That's like 1 out of 10. So yeah, that's kind of a lot. In addition, from 2009 to 2019, the share of high school students who reported persistent feelings of sadness or hopelessness increased from 26% to 37%. So that's more than a third of high school students reporting persistent feelings of sadness or hopelessness. And I think paying attention to the wording there is key. Feelings like sadness, they're common. We all feel them. You might have felt sad yesterday. You might feel sad in 10 minutes from now. Those are fleeting feelings, okay? Like when you're on the freeway and someone cuts you off, you're angry, but you should be, hopefully you're not angry all day after that. But like the anger should subside within a few minutes. This is saying that these students have had persistent feelings of sadness, meaning it wasn't minutes, it wasn't hours, it was probably days, if not weeks, where they felt like this. Also, suicidal behaviors among high school students also increased 44% during the decade preceding the COVID public health emergency. Again, stats pre-COVID, with about 16% having made a suicide plan in the prior year. Between 2007 and 2018, suicide rates among people ages 10 to 24 in the United States increased by 57%. That's an alarming statistic. Early estimates show that more than 6,600 suicide deaths were among this age group in 2020. That's a lot. That's a lot of suicide that has occurred in a very young population. I mean, you look at that, that's 10 to 24, granted, that's spanning from elementary school to already people who are hypothetically out of college or about to be out of college if they're going to college. So we have, a very large developmental span, but your brain isn't fully developed until mid-20s anyway. So we're looking at people who have committed suicide before they're, fully developed cognitively to even manage life or assess these situations. It's a very sad statistic. Okay. Let me, a few more stat slides. I think I have 2 or 3 more. ADHD, anxiety problems, behavior problems, and depression are the most commonly diagnosed mental disorders in children. Estimates for ever having a diagnosis among children aged 3 to 17 from 2016 to 2019 are given below. Okay, so for ADHD, I'm going to round. Approximately 10% of kids will have ever been diagnosed with ADHD. For anxiety, it's about 9.5%. For behavioral problems, it's about 9%. And for depression, it's about 4.5%. It's still quite a few people. Some of these conditions commonly occur together. That's very true. In fact, we call this comorbidity, and comorbidity in the field of psychology means there's 2 diagnoses occurring at the same time. They're occurring concurrently. Whenever there's comorbidity, it makes treating either one of the diagnoses, I say either one as if there's only 2, sometimes it's 3, sometimes it's 4, but whenever there's comorbidity, treating the issue at hand becomes more complicated because I'm not dealing with one thing, I'm dealing with multiple things. And so comorbidity is common. And here are some stats about what type of comorbid conditions we typically see in children and adolescents. So having another mental disorder was most common in children with depression. About 3 in 4 children with depression also had anxiety, and almost 1 in 2 had behavioral problems. The thing about depression and anxiety, I say that they go together like peas and carrots. They really do. And this is common for adults too. When adults present with what we call a mood disorder like depression, they are much more likely to also present with anxiety and vice versa. And so we see the same phenomenon with kids. Kids that are depressed, most of them are also anxious. And so again, we're treating 2 different things. They go together, they're constantly co-occurring, but I don't treat them the same way. I have a very different protocol for anxiety than I do for depression. And so in kids like this, we have to figure out which we're tackling first. And how to address both of these issues simultaneously. For children with anxiety, more than 1/3 also had a behavior problem, and about 1 in 3 also had depression. And then for children with behavioral problems, more than 1 in 3 also had anxiety, and about 1 in 5 also had depression. Also, with comorbidities occurring, it kind of makes it hard to figure out, like chicken or the egg, which one came first. Is one kind of influencing the other? Are these two separate things, or are they symptoms of the same thing that are just manifesting differently in this particular child? I mean, I guess the short of the long when it comes to comorbidities is they really complicate the clinical picture and they really complicate treatment. Okay, the last slide on statistics. For adolescents, depression, substance abuse, and suicide are very important concerns. Among adolescents aged 12 to 17, in the years 2018 through 2019, these are the stats that we have. About 15% had a major depressive episode. And I just, my little disclaimer here, that's met full criteria for a major depressive episode, which includes that the symptoms were present for 2 weeks. So again, if you had a kid who was depressed for a week and a half, that's not criteria. So we have 15% meeting full criteria for a major depressive episode. We have about almost 37% had those persistent feelings of sadness or hopelessness. About 4% had a substance use disorder. Same disclaimer applied here, not experimenting with substances, not using substances, but using them to the degree to cause impairment, using them to the point that they're actually meeting the full criteria for the diagnoses. And that indicates obviously a big problem. And then almost 19% had seriously considered attempting suicide. Okay, educators do play an important role in identifying children that may be dealing with these issues, because educators spend a lot of time with these kids. If the kids are in school, what is it, 6-7 hours a day? I don't know. I forgot. I haven't been to school in a long time, but somewhere along those lines, that's a long portion of their day where they're away from their home and their family, and they're under the supervision of teachers. And so teachers can see these things that potentially are being missed by others. They get to interact with the kids in a very meaningful way. So yeah, I think it's really important that educators know a little bit about mental health issues, and also what to do if they suspect that a kid of theirs, a student of theirs, has a mental health issue. Okay. Oh gosh, that's kind of hard to read. I'm going to read it on my other screen. Okay, so I put in the abuse and neglect slide because I think it's important to remember that we are mandated reporters. All educators are, all mental health professionals are. If we suspect abuse or neglect, we do have to report it. Also, I put this in there because sometimes kids who are being abused or neglected, some of their symptoms that we encounter might look like depression, or it might look like anxiety, but in reality, it's coming from something else, or they are concurrently depressed and also being abused. But just a recap, a lot of you are probably familiar with the warning signs of abuse and neglect, but I'll just go over a couple of them. Obviously, cuts, bruises, broken bones, injuries, burns, things like that are obvious. You might see bruises on the arms, you might see cuts. Granted, little kids do fall down, so we have to keep that in mind, but a lot of times what you'd see is a kid who has a lot of unexplained injuries. Constant hunger or thirst, a lack of interest in surroundings. That's something that also that mirrors depression. We see that with depression, we see that with abused kids. And so that one might be complicated to suss out which is which. A kid who is dirty, a kid who has a lack of supervision. So maybe the parents are super unresponsive. The homework's not getting done, reports aren't getting answered, parents aren't communicating or responding. Maybe they're not picking them up on time, stuff like that. Pain, bruising, or bleeding in the genitals, which is something you as teachers probably would not be aware of unless they're particularly little. more knowledge about sex than is normal for the child's age. Yeah, that's a pretty good indicator. Of course, you know, devil's advocate, maybe they have older siblings, teenage siblings. A lot of times a teenage sibling, you know, can taint the poor innocent minds of these young kids. But you want to pay attention to that, because when these young kids have knowledge about sex and you're kind of like, wait, what are they talking about? They're too young. Where did they get that info? Okay. Is it an older brother or sibling? If not, and honestly, it's not your job to play detective, but you do want to think about these things, because that is abnormal for young children to have knowledge or interest in sex like that. And then also the last bullet that they put is hard to believe stories about how accidents occurred. Okay, so who do you refer to? You have a kid presenting with some sort of symptoms, and we're going to talk all the symptoms of ADHD, autism, depression, anxiety. We're going to talk about those in the next webinars. So just remember this and then relate it to that. When you encounter a child, a student that's presenting with some sort of issues, like, who do you refer to? So let me explain who all these people are and what they do, and then we can kind of figure out who to refer to. So a BCBA is a board certified behavior analyst. Behaviorism is a subset of psychology. Well, I'm biased, so I'm going to say it's the best subset of psychology. But we are the most scientific subset of psychology. And so everything that behaviorists do is data-driven. They're very good at understanding the environment and how the environment affects the child. Behaviorists are trained in basically how to reduce problem behavior by teaching children replacement behaviors or pro-social adaptive behaviors that help them achieve like optimal independent functioning. The majority of our field, and I say like unfortunately, because to be honest, behaviorism should be used everywhere at all times, but the majority of our field is dedicated to kids with developmental disabilities. So when we see kids presenting with autism spectrum, the #1 recommended treatment of choice is behavior analysis, and also ADHD. I think BCBAs are probably the best go-to for kids with ADHD related symptoms. And I'll talk a little bit more about that on like one of the subsequent slides. An LMHC is a licensed mental health counselor trained in dealing with psychological disorders, depression, anxiety. This is what we think of when we think of traditional talk therapy. Now, plenty of these people will see young children. I personally will not, because I don't find it to be super effective to do talk therapy with children, but it's an individual preference thing. A licensed mental health counselor is definitely more appropriate for a child with depression than would be a BCBA. Now, an LMFT, that's a licensed marriage and family therapist. So granted, it's in the name, they do marriage therapy, but they do family therapy, and they're very good at looking at dynamics. Personally, I think young children who are experiencing depression or anxiety would be better suited by an LMFT than an LMHC, because when you have a young child, a lot of times what you have are environmental problems or problems within the home dynamic that are affecting the kid. And an LMFT is very good at assessing dynamics and helping the family become more cohesive and overall more healthy. A psychiatrist, contrary to popular belief, does not do counseling. A psychiatrist goes to medical school. They don't go to clinical psychology school. They're not trained in psychology the way that a psychologist or a counselor is. And so a psychiatrist, their primary function is to prescribe medication or adjust medication. Now, a psychologist does everything that a licensed mental health counselor does, but they also do psychological testing. And so sometimes that's a necessity for insurance benefits, or in order for a kid to access some type of service, they'll have to have a psychological test. So that might be they need a diagnosis for ADHD, or like in the case of behavior analysis, Medicaid has a requirement that any child trying to receive behavior analysis services has to have a psychological evaluation that diagnoses them with, one of the qualifying developmental disabilities. So a psychologist is I think like psychologist and mental health counselor both can do talk therapy, both can treat these disorders, but only a psychologist can diagnose and do the testing for them. Excuse me. All right, some schools of thought in psychology. So I wanted to bring this up because I think there is a misconception of psychologists and therapists nowadays. And I'm going to go ahead and blame that on social media and TikTok, okay? Because I see so many videos nowadays of psychologists on TikTok, and they're telling, they're saying their point of view, and this is how we need to treat clients, and this is what we need to do, and blah, 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 blah. That's one school of thought. In psychology, we have so many schools of thought, and sometimes we contradict each other. And so it's quite possible that me, coming from a very behavioral perspective, if I'm sitting with a clinician who comes from a postmodern perspective, and we're looking at the exact same individual, we might have two very different opinions as to what the problem is, and we're definitely going to have two very different treatment approaches. And so I want to inform you guys, educators out there, so that when you see this pop psychology that exists, you can maybe, look at it with a grain of salt, like, I don't know, but that you also understand there is no one way and no one method to look at or treat problems. So some of the schools of thought, we have CBT. That's probably the most popular and the most common in the mental health realm. And so that's cognitive behavioral therapy. Then we have behavioral or behaviorism. We have reality therapy. There's psychoanalytic therapy, postmodern, feminist, existential, and there's way more than that. No one model is superior. However, there are models or schools of thought in psychology that have more empirical evidence, which means there are schools of thought that are better supported by science. And those two are CBT and behaviorism. So CBT is well documented, well studied, and is the treatment approach that is recommended for depression, eating disorders, among many other things. Behaviorism also, when we're looking at anything anxiety, panic related, anything relative to autism spectrum, the go-to approach, according to research and science, is behaviorism. So no school of thought is superior to the other, but some schools of thought have a lot more evidence behind them. The new age social media psychology, a lot of that new age psychology, and some of it's pseudo psychology, much of what I see nowadays on those social media platforms is coming from a more modern perspective. And so it's coming from what we call postmodern psychologists or feminist psychologists. Those are two schools of thought that do not have a ton of research substantiating their efficacy, but things like if you hear people saying like, own your truth, or like you need to validate or affirm, that's coming from that school of thought. So like I said, that's probably the most common in social media, but you have to understand there are so many other clinicians that are probably approaching these things differently. My personal emphasis, as I said, I'm a behaviorist, but I also very much like reality therapy and existentialism. So I make a strong emphasis on the importance of a person's relationships. Are their relationships healthy, especially for kids? How are their social relationships, but also how connected are they to their family? How independent are they? How much personal responsibility is, when it comes to kids, like when it comes to adults, we can say you're not taking responsibility. When it comes to kids, we have to teach them and give them opportunities to take responsibility. And we also look at things like choice and motivating variables from my school of thought. I did include a couple of articles here. I'm just going to exit the slideshow for half a second and come back in. I just wanted to show you a few articles that I pulled up. I'm not going to read the articles, but just so you can kind of see what some of the research says. Most of these are geared towards ADHD, but we've got some really good research on, excuse me, I just cannot get rid of this thing. Okay. We've got really good research on environmental/behavioral treatments for ADHD that does not include medication. I'm looking at this now thinking that this probably should have gone on next week's webinar relative to ADHD, because all of it is. But more research again, coming from a CBT/behavioral orientation where we are very research oriented, looking at negative effects of stimulants that are prescribed to kids with ADHD. Again, how academic performance could be influenced by ADHD. Believe it or not, the majority of studies indicate that they don't necessarily perform better even when they are on the medication. They might be less active, but not performing better. And then how the role of teachers' attitudes will influence the level of treatment that these kids receive. So all of those I thought were kind of interesting. All right, let me go back to the slide. There we go. Okay. All right. So, all right, more about the schools of thought. Believe it or not, we don't always validate someone's belief or feelings. Again, that's kind of more of a postmodern feminist approach to psychological problems. From a CBT school of thought, we actually challenge quite a bit. We confront what we call irrational belief systems, what we call automatic negative thoughts. And so two very different views on how we would approach the same problem. Also, we don't always need to intervene. Obstacles and challenges can inspire feelings of confidence when the child learns how to get through them. We need to make teachable moments, not easy pathways. That's something, and this is an anecdotal thing that I'm sharing, right? That's something that I've observed quite a bit, is that nowadays adults, parents want to clear the path for the kid and make it easy for the kid, that the kid shouldn't experience any discomfort and they shouldn't have to struggle. And there's nothing to be learned if we allow for that. And so in reality, it's good for these kids to have obstacles and challenges. What they need an adult, therefore, is not to clean the street for them. It's so that we can help them. We can say, like, do you have any questions? We guide them, we support them, we give them courage and strength to get through the obstacles, but we don't move the obstacles for them. This inspires feelings of self-efficacy and confidence. Self-efficacy, that's a big term we use in psychology all the time, but it's this feeling that, yes, I can do it. And if there are no obstacles for a kid to overcome, how is he ever going to develop this feeling of, yeah, you know what, I can do it? I put scaffolding in here. That's another term we use when we try to basically orchestrate situations that are kind of difficult, not impossible difficult, but like light to medium hard, right? So that the kid can get through that obstacle, learn something, and feel a sense of confidence. And so when you scaffold, you want to pay attention to their ability level, kind of meet them where they're at, and then just up it a bit, so it's not easy. It requires some challenge. Also, I put this on here because I think this is very important and also ties into some of the more new age things that I'm seeing in social media. Not all mental health professionals believe in a diagnosis. Many of us do not like to diagnose. We do not like to label. I think that is, something that's growing in popularity among younger generations, is they're all talking about their mental health diagnoses, their mental health labels. Some of us don't want to give those labels at all. Many of us have to, because unfortunately we're bound by insurance companies that require it, right? So there's that. But also many of us are not, we don't believe in the use of medication for the treatment of disorders. There are plenty of therapists who will encounter a client with depression and say, you need to go speak to a psychiatrist. But there are a whole lot of others that say, no, that's okay. We've got this. You don't need those medications. We'll change the environment. We'll change what you do. And so I think sharing some of those articles that I did a couple minutes ago, we could use those here as well. And the idea that, like, these children might be going through something, but medication doesn't have to be the ultimate outcome or the ultimate treatment approach. There's a lot of things we can do environmentally, and a lot of different types of therapists that will approach that and say, okay, let's try X, Y, and Z instead. Okay, so I think that's going to bring us to the end of the presentation for today. I'll show you my references. So this was kind of the shortest one because we're just giving you the brief overview, but I do hope that you guys come back or you tune in via online webinars, whatever, and you check out the subsequent webinars that are about, thoroughly breaking down ADHD, autism, depression, all of that. And I will talk a little bit about like environmental / classroom strategies that teachers can implement when we do those webinars. But for now, are there any questions? I mean, we'll do a little Q&A for a few minutes that we have left.